Good afternoon. Thank you, Dr. Subhash, for having me in this course. We know that a robust vitreoretinal department is a boon for a cataract surgeon. But they also return the favor by creating some situation where we'll have to chip in. Like they put silicone oil, and I think they will all agree that they will intractable glaucomas of silicone oil glaucomas. And also we do get cataracts which actually happen after a process of vitrectomy. But what is the difference if you are operating a patient who has been vitrectomized? So vitrectomized eyes, when you are doing a cataract, the problem is the anterior chamber is very deep because there's a low scleral rigidity. AC becomes you need to vertically really go down to, hold on to the lens. And there's a possibility that during the previous vitrectomy, there is probably a damage of whatever degree to the posterior capsule. So the possibility of a posterior capsular rupture and a nuclear drop. And these patients usually are diabetic, so they'll have medical fitness issues. And if you're doing any conjunctival surgery like SICS, then you'll have some conjunctival scarring and things like that. So, but basically what is the whole problem is when you are operating any vitrectomized eye, should always entertain the fact that there's a possibility of such a disaster happening. The nucleus can drop if you don't really take care. So I'll just probably show another case why this deep AC becomes a problem. If you do not have something like an active fluidics where you can control the IOP and maintain the AC depth, you can probably use the side port leakage as an advantage. I've made a little larger side port. I'm sort of depressing the side port intentionally. It's a mistake by the juniors normally, but here we are doing it intentionally so that we have an excessive leak from the AC. So a vitrectomized eye, even though instead of having a deep chamber, you will probably get back to some normal, decent depth. So this could be one, if you cannot really reset your parameters, at least you can use this intentionally leak, press the side port to have a more leakage. And also, many of these cases will require some follow-up treatment, like post-cataract, they would like to see the retina again, maybe would like to give a laser treatment or something which may be a contact procedure. So always it's better to suture the main wound. So even though it may be 2.2 or 2.8 and maybe a well done one, but it's always better that you can never be sure. So always put a stitch if you are contemplating some procedure immediate post surgery. And probably the small pupil is one big bugbear because most of the patients are diabetics. Sometimes the previous inflammation following the vitrectomy would have caused some posterior capsular, some posterior synechiae. So small pupil, so we always take pride in operating patients with small pupils. But here we need to probably change our methodology and the philosophy. It's not important that you do a cataract surgery in a small pupil, but whatever after cataract, there is some vitreoretinal procedure and follow-up is required. So use this cataract surgery to manage this pupil also. Leave the pupil always bigger than what you found it as. For example, in this case, I also gave a small tip. When you're using your post-op medication, we normally put a mydriatic, a tropicamide phenylephrine combination once at night or something, which normally mid-dilates the pupil. And every time you do the same thing, you put only one drop at night, every time it dilates to 4 millimeters and goes back. So then there'll be a addition of the anterior capsule to the back of the iris. So this pupil will never dilate beyond 4 millimeters because it never got dilated more than that in the post-op period. So maybe if you put once it dilates to this, you put second times it dilates to maybe 6 millimeters. So always instruct your patients to put a mydriatic twice at night with a half an hour gap so that you achieve an optimum dilatation, okay, at least in the first week where the inflammation is high. So keep the pupil mobile by increasing it. I think we always say vitreous is our enemy in cataract surgery, but it's the other way around. I always want to say we love really vitreous because I'm just giving you an example. This is a patient I was operating, and when I was doing, you can just see, I just went to the end of the trench and there was a PC rent there, which I did not notice. Later I realized that there's a PC rent there. So once you have a PC rent right in the beginning of Phaco emulsification, now you have very good premium viscoelastics like chondroitin sulfate. You can go to that area of the PC rent, inject there, and then try to seal that area, try to create some kind of a platform, okay, on which you can continue. There's in the periphery of the capsule, there is a thing. So I'm going with the viscoat, trying to fill that area, so sort of create a some kind of a scaffold on which these pieces can be emulsified at a little higher plane. So keep on injecting this again and again. You can continue to, that's because the vitreous is gel, it is remaining there, and the gap we are going to close with this viscoelastic. But at the same time, if you have a vitrectomized eye, see, we have a different picture altogether. This is a vitrectomized eye. This cataract had happened within 6 weeks of the surgery, which unfortunately I did not know. So I just started, I knew it was a vitrectomized eye only. This cataract, the onset of cataract to the VR surgery is very important. If it happens very quickly, beware that probably there's a damage to the posterior capsule. So I still knew this could happen, so I did a Rexis for sure because I may have to put it in this sulcus. We kept the IOP at 30 in order to see that, see this, we have kept a low IOP in order to manage the AC depth. So I started doing, I did not do any hydro procedure, if you see. I did not do any hydro procedure, and I started actually chopping it because this fluid should take care of that. I suddenly saw a part of the piece started going down, and then, so there was a pre-existing PC rent. So now I am trying to pump visco into that area, try to create a scaffold like the previous case, but it is very difficult because whatever I put there gets into the vitreous cavity. There is no vitreous there. So now we realize that our old evil vitreous is actually so friendly. Okay, when you don't have it, whatever you don't have, then you realize the importance, whether it is your spouse or student or any friend or whatever. When you don't have it, then you decide, now I'm really missing my vitreous there. So I had to really keep on pumping tons of viscoat or visco, just try to sort of bridge that gap so that I could operate that in a higher plane. But even then, a lot of things have already gone down. So now I had to change from topical to subtenance. So I gave a subtenance on the table. I put a bit of, dilated the pupil with a bit of epitrate, and then try to remove as much, because when we shift over to the VR surgery, we want to clean up the whole capsular area at least, because so that their visibility is good. So I did a dry aspiration and tried to remove this epinucleus with difficulty. It's so difficult because it keeps on slipping down because there is no support. There's no vitreous support, and vitrectomized eye collapses like this. If you have a vitrectomized eye, so you will have a collapse once this happens. So I had to really keep on forming the AC with the BSS, and now I had to remove all there's a large PC that you can make out. So I did that, and immediately in the same setting, our VR colleagues, did the rest of the job. So for them, they have a huge space, so they can easily go and do it. And then we had the Rexis intact in the same setting. We could implant a 3-piece lens in the sulcus, and we did the optic capture also. So this is the kind of situation that we may be facing if you have a cataract which follows immediately after a VR surgery. So, but the ultimate aim is whenever you're doing a cataract surgery in a VR vitrectomized eye, your main aim is to give a clear cornea, because there are a lot of VR procedures that may be still pending or waiting to be done in the post-op period. So make sure you take care of your cornea well. Choose a procedure, whatever technique that is required to leave the cornea free. If you have a cornea like this, I don't think they will be able to do anything. They may be having some retina procedures still pending. Okay, so the take clinic messages are, there is always treated like a posterior polar cataract. A PC weakness, posterior capsular weakness is imminent. So you can use a pars plana infusion. See, whatever the surgery I showed, this could have been ameliorated, or maybe I would have been better off if I had put a pars plana infusion. And for an anterior segment surgeon who can do a very complex surgery like a cataract, putting an infusion port before the surgery is no big deal. I think people should start, learning how to put an infusion, and always leave the pupil larger. If you have got a small pupil, try to stretch it, try to see that you have multiple sphincterotomies, or in post-operative period, try to use mydriatics adequately to keep the pupil larger in the night. And all these patients will have a severe inflammation normally. So try to take care of inflammation so that you will not have a macular complications. And obviously these patients, you cannot assure very good visual recovery because they already have a posterior segment disease. So you need to talk to them before the surgery and talk to them into this so that they actually understand that we are only doing a part of the job. we are not trying to restore all the vision that they have lost. Thank you very much.